Welcome to the February NASPHPD Meet Me Call. Today's Meet Me Call will highlight potential societal and economic impact of scaling coordinated specialty care for first episode psychosis. We are honored today to have Kana Enomoto, Director of Brain Health with McKinsey Health Institute, and Kevin Collins, Associate Partner with McKinsey & Company, who will be highlighting a white paper titled Scaling Coordinating Specialty Care for First Episode Psychosis, Insights from a National Impact Model. This white paper and national model are the result of collaboration among several partner organizations, including NAMI, National Council for Mental Wellbeing, McKinsey Health Institute, and NASPHPD. We want to thank Kana and McKinsey Health Institute for putting together this collaboration and for all their contributions to improve mental health in the USA and around the world. Kana, please go ahead.
Thank you, Brian. And thank you so much to NASPHPD for having us here, for NAMI National Council and Mental Health Services Oversight and Accountability Commission in California for the partnership in developing this national model. I think we had a chat maybe last September, October, where we were sort of musing about the progress over the last so many years and how this was an area that, despite the strong evidence, we really as a nation were not making as much progress as we might. And the cost to human potential, families, communities, and the economy was so significant that we really might try to re-energize some efforts on first episode psychosis and coordinated specialty care. And perhaps that doing a sizing of the impact of the economic value of first episode psychosis care, coordinated specialty care, could really make a difference in terms of helping governments, businesses, employers, communities understand the value of investing in this particular intervention. And so we set about to create a financial model that would help first create a national estimate of what is at stake, and when and how could we see the potential economic benefit of this. So if we go to the first page, I'm not going to, and I will just, spoiler alert, like, this is not a first episode psychosis like clinical paper. We are not presenting anything on that front that you don't already know. Most of you are incredible experts already in the field. You know what your states are doing. States have stepped up and are investing a lot because this is a important population, right? Like over 100,000 people a year are experiencing their first episode. Still, we have an unacceptable duration of untreated psychosis in our country. It's much shorter than it had been. But still, we know that 2 years is too long to make the kind of clinical impact that we could see. And then we have the impact on the life expectancy that our sisters, our brothers, our sons and daughters who have psychosis have shorter life expectancy and worse health outcomes, 3.5 times more chronic disease. And there's so much that we could be doing earlier on. And then that we have a gold standard of care, right? This has been acknowledged by the American Psychiatric Association. This is what people should get for early psychosis. And yet we don't see this getting scaled in the way that it should, right? 3 out of 4. If there was any other serious condition for which 3 out of 4 people would see remission of symptoms with treatment, there would be an outrage that not everybody had access to that treatment. And yet here we are without that. And we're estimating, as we'll get into a little bit later, that perhaps 1 out of 10, most 2 out of 10 in some places, people who are experiencing this are getting access to care. So I think, as you all know, CSC is an intervention that includes psychotherapy, medication management, family education support, service coordination, and support education employment. We also looked at the model that includes peer support as a vital component. It'll be on the next page. So this was the original model. But we know that having peers engaged is also vital to the success of the program. And so as we had looked at it, we did include that in our estimates because so many programs have shown efficacy in that approach. And then also in the acknowledgement that people may have more complex presentations and co-occurring conditions. So, CSC, it can have an impact on reducing hospitalization, reducing ED visits, less CJ involvement, less criminal justice involvement, and reduce adverse or negative symptoms. And also, it has the potential to improve positive outcomes so that people have better quality of life, that people are more likely to be able to finish their school and get jobs. And yet there is component of this that has to do with building brain capital, right? So as we are in this age of technology, this age of an evolving workplace, more than ever, jobs that include brain skills and require brain health are emerging as highest priority for employers. So World Economic Forum just had its meeting in January in Davos, and they published a jobs report. And currently in 2025, the top 7 out of 10 job skills in demand for employers are things like creativity, resilience, adaptability. And then even as you think about technology being on the rise, in the next 5 years, they still see brain health and brain skills as critical components to competitiveness in the economy. And so I think there's a place to tie this conversation around early psychosis, this conversation about early intervention, and the financial benefits that you could see by making this investment into the conversation around the brain economy that I think is really starting to be on the rise. So again, grateful to all our partners for especially Brian and Jessica, who were fantastic in coming together to do this work. Dan and Darcy at NAMI, Toby Ewing at MHSOAC, and of course Chuck and Golia at the National Council, who all were fantastic thought partners as we were on this process. And with that, I will hand it over to Kevin, who will walk you through the model.
Thanks, Kana. Thank you. So maybe just let's go back one slide if you don't mind, just to cover one key point of information. So one, of course, positive point though is that the number of CSC programs in the U.S. are growing substantially and have been for the last number of years. But however, the important starting point is that the access that's available today compared to the amount of need is still, as Kana mentioned, still there's a large gap. Information in 2021, for example, estimated around 24,000 clients receiving care in a CSC program compared to around 100,000 if you're using some of the best epidemiological estimates of this, around 100,000 new cases annually. And so as we go through the kind of how we approach this question, we're going to use a range of around 10 to 25% of individuals receiving access as sort of the starting point. And as you'll see in a few slides, we'll try to imagine if we were to take that to a higher range of something like 90% of people receiving access, what does that mean in terms of the potential system savings impact as a whole? So if you could just go to the next slide, please. So we'll start with a big number. We'll start with just kind of what's the main conclusion, then we'll walk through how we get there. But if you are to take the 10 to 25% of people that experience first episode psychosis annually, and imagine we brought that to 90%, over a 10-year period, we estimate the number of additional individuals receiving timely access to high quality care could be 600 to 800,000 individuals, and this is nationally in the U.S. And that could translate to around 115 to 140 billion dollars in total savings, and that's across a number of different categories. That includes healthcare savings as well as impact on increased employment, savings from housing and criminal justice, and so we'll talk through where that comes. But in an aggregate nationally, this is almost a million individuals receiving additional care and north of $100 billion in total savings. Next slide, please. So just grounding on before we talk about the model. Of course, there are two sides to this, right? The model will speak a lot about cost savings, but of course, there's just simply the improved outcomes, improved quality of life, life expectancy, the impact on caregivers and families, and not only is the CSC program dramatically improve on those kind of direct measures of better outcomes, but also cost savings. And so we're going to spend a bit of time just focusing on the cost savings, which the model is really digging into. Next slide, please. Just one sort of grounding disclaimer before we share a few of the statistics. The kind of mentioned some of this, but the model itself is a best synthesis of existing research. So we poured over the literature on first episode psychosis, coordinated specialty care, reviewed, included at least north of 50, probably closer to 100 publications in this work. But it is a synthesis of existing research, not, of course, net new clinical research itself. It should also hopefully serve as a potential fact base for, we hope, for state community leaders, policymakers at state and the national level for why this is valuable to invest in and expand access to. But a few things it does not do is it's not novel information on the clinical effectiveness of timely intervention. That's well demonstrated already by the clinical literature. This model just, again, synthesizes that and puts it into a dollar figure. It doesn't propose exactly how CSC should be gone about. There are different, of course, as you know, different models for how to deliver CSC. It does not propose an approach to that, nor does the model look into the sort of more upstream actual prevention of the incidence of first episode psychosis. This is assuming we have a relatively consistent rate of incidence, and we are getting that population timely access to care. Next slide, please. Great. So just to sort of think about how we looked at the populations to actually perform the analytical exercise. This model focuses on the U.S. population age 15 to 34. And we, of course, look at that as the population who are experiencing first episode psychosis in a typical year. And as you'll see, the model puts that at around 120,000 individuals nationally. And then there, of course, are individuals who are not experiencing first episode psychosis. Of those who do experience first episode psychosis, so second column on the page, there are individuals who receive coordinated specialty care, and there are those who do not. And then finally, there are, of the individuals who do receive coordinated specialty care, so third column, there are those who receive timely access. So the way we're defining it here is in the first 12 months. And then those who receive delayed access. And our model makes an attempt to compare those different populations because the outcomes in terms of sort of impact on quality of life and as well as system costs are very different between individuals who do not receive coordinated specialty care, individuals who receive timely access to coordinated specialty care, and those who receive delayed access. So there's different outcomes for each of those populations. Next slide, please. And so lots of numbers on this slide, but this is just sort of the first kind of what does the model tell us? So what you're looking at here is there's 4 columns. There's each of those cohorts that we mentioned on the previous page. There's comparing community care, sort of not receiving access to coordinated specialty care, but you have first episode psychosis. There's the population that does receive coordinated specialty care, actively in it. There's the population that received coordinated specialty care in a timely manner and is now in ongoing care. And then there's the population that received coordinated specialty care, but not timely, but delayed, but are now in ongoing care. So in a typical year, you can imagine people being in one of these four buckets, categories when it comes to individuals who have experienced first episode psychosis. And what we've made a attempt to do with this model is to quantify the total cost per person, system cost, based on a few categories inside of those. So for example, you'll see in the sort of the status quo of not receiving coordinated specialty care, around 150,000 or 148 on the left-hand side, around $150,000 annually is spent on an individual. That would be across outpatient mental health services, other healthcare expenses, employment costs, housing, criminal justice, and caregiving expenses. If you're comparing to someone who's actively in a CSE program, the total actually looks almost similar. However, there's a difference between the mix. So a lot more is spent on outpatient mental health services, as in the actual delivery of coordinated specialty care. However, there's less expense on employment services, there's less expense on caregiving, and so on. But what's really important is the last two columns. So if you look at someone who went through a CSE program in a timely manner, so this third column here on the page, the literature shows that the actual total costs from a system are substantially lower. And that is from really across the board, but you'll notice largest savings on other healthcare expenses. These are things like fewer inpatient stays, emergency department visits, improved overall medical status. Employment expenses are usually lower as well. And then if you compare to the fourth column, if you were to receive coordinated specialty care, but it was delayed, so not timely, again, we're defining this as not in the first 12 months of experiencing psychosis, you can see that the costs are actually higher. So really what's important to know is timely access is the big driver of what are potential cost savings. Next slide, please. So in order to actually translate this to, a sort of a national figure of how much impact this can have, started previously with impact at an individual level, and now we have to imagine this, how this plays out over a number of years. So what we've simulated is a 10-year scenario of where you imagine a shift in who's receiving access. So a baseline is, imagine we're sort of continuing in the status quo, 10 to 25% of people receive access to coordinated specialty care. You can see how the number of individuals sort of shifts over time to year 10. So in year 10, around 1.2 million people have experienced first episode psychosis, yet in terms of who ended up in that ongoing care, early access to coordinated specialty care category, it was around 98 to 244, so around 100 to 250,000 individuals. If you were to imagine a world in which 90% of people received access to care in a timely manner, so that's the bottom chart, you can see that that number by year 10 is A, the majority of the population, and B, much larger than the baseline scenario. So if you were to compare these two scenarios, again, where individuals are receiving 90% access instead of 10 to 25%, the number of extra individuals that end up going through a CSE program is around 600 to 800,000. Next slide, please. And so when you actually turn that into combine these two things, you turn that into a number at the national level, 600 to 800,000 additional people receiving timely access to coordinated specialty care, knowing the kind of different outcomes in terms of system costs that those two sort of scenarios lead you to. It leads to around 140 billion in total system savings nationally. Of course, this would, be state by state. This might vary, and of course, is state by state the figures would be smaller. but 140 billion at the national level. And you can see how the two scenarios are different. So in scenario A, where 10% of people receive access, we, for example, spend around 35 billion on outpatient mental health services, compared to 90% access, we actually are spending more on outpatient mental health services. Whereas other healthcare expenses, again, things like inpatient emergency care, we are spending less as a result, going from 357 billion to 319 billion. So this is really a classic case of investing in outpatient mental health services to drive down aggregate system costs as a result. And the literature strongly supports that based on all the sources we've been able to compile for this model. And I'll just preempt that we have this laid out in plenty of quite a level of detail. We have a technical appendix for anyone who would like to actually go through the sources and really understand kind of what each of the individual impacts are. And I'll cover some bit more of that later. But this is the sort of the highlight figure, if you will, of what the literature says about potential system impacts. And I think I'll pass it back to Kana to cover a few more points. Kana, I think back to you.
Yeah.
Thanks.
Sorry, I had a double mute situation. So, as we are thinking about what does it take to expand access, it's not, this is, I hope nobody feels like this is a call where we're telling the states that you need to be doing more than you have been, in that I know that most of you are kind of implementing CSC to the extent of your abilities or your funding. So, it's a multi-pronged approach, I think, is needed. So we first would need to, I mean, if we were to get more people to in that early 12-month period, it is necessary to enhance awareness, screening, and outreach, which is not always that easy to find young people where they are. We know that there's a group of kids with SED who are probably at higher risk that we could perhaps get to. And I think that was some of the work that folks have been doing with the clinical high-risk populations. But still, it has to be broader than that. And that means reaching kind of broadly communities, pediatricians, teachers, schools, et cetera. We don't, if we had, someone waved a magic wand and said, oh, here, you can have the 1,000 more CSC programs that you need, we wouldn't have the workforce for them. So how do we build the workforce? How do we train folks so that they are prepared to deliver evidence-based coordinated specialty care when we have the resources to do them? It's obviously funding. So while we can show the picture of like in 4 years you'll start saving money, it's not the money doesn't get accrued necessarily to the behavioral health system. So how do we do that? And we know that a large proportion of people who have first episode psychosis are not on Medicaid or they're not on Social Security. So how will we cover their care when very few commercial plans are covering it? And, there are a handful of states that are leading the way in terms of requiring commercial payers to cover coordinated specialty care as a team-based intervention. And in many cases, they're really just covering the what they see as the medically necessary, the traditional medical services, which is insufficient to really scale this type of program. And then how do we create, which I think is already, in development, but in the bigger picture, how do you establish the infrastructure and accountability mechanisms to other programs? So, we have EpiNet, we have other data that are being collected through the block grant and beyond. But if this becomes something that's scaled beyond the public sector, how do you have the infrastructure and accountability to monitor the quality and the outcomes in that? Next page. And so we think that the states do have an important opportunity, though, to highlight the savings that could be accrued through CSC program expansion, and that's sort of why we're bringing this to this Meet Me call. We're bringing this to other settings because we have been able to narrow this down for a state, and that's the intention of this, is that you could use this as a tool to identify what is the value at stake within your state. How do you develop a policy kind of framework for this and for what would be needed, particularly in your state's context, and then use the potential impact data to make the business case for changing benefits, whether that is within Medicaid or changing, working with the Department of Insurance to change it more broadly, and then just spreading awareness to other state leaders, because this, as we have mentioned, the value at stake is not just accrued to the health department or to behavioral health specifically, but to other of your colleagues who are in corrections or justice or education or labor. And so the idea is that this tool could give you some data that you could take to support those conversations. And again, on the right-hand side is the amazing experts. So we did talk to NIMH, we talked to the model developers, we spent lots of time with folks who have been studying this for decades, and so we appreciate their contributions to helping us develop the model, refine the model, test it, and so forth. So with that, it looks like there's a number of questions in the chat, and we can look at that. Kevin, anything you would add?
I think maybe also kind of just before we do the questions, we could look at just a couple additional, since we have the time, I think a couple additional slides in the appendix. If that's okay, I could ask. Thank you. You just jump one more slide forward. So we just wanted to share a couple more points of color of how the how some of the what's going into the estimates. So we mentioned healthcare, employment, housing, criminal justice, and caregiving is what the model actually measures. So it doesn't actually measure things like it doesn't sort of account for actual quality of life improvement, DALYs. Like these are really just system costs. So for example, healthcare includes both medical and behavioral expenses. Employment does include regained income due to unemployment, which is a big driver. Housing is both supportive housing and changes in the amount of unhoused individuals and the supports required. Criminal justice includes the reduced costs of criminal justice involvements, and that's detention costs, arrest costs, probation. And caregiving includes both income loss and annual differences in spending for individuals who are caring for someone with psychosis. So if you could just go one more slide. Thank you. So I won't walk through this in all detail, but I just wanted to share for those who are sort of building a case for all the different impacts of how CSC leads to better outcomes and savings, this may be a helpful resource. So it takes each of those categories. We've got healthcare impact, and then the next few slides cover the other categories. You can see very specifically what sources were we using, how does the actual impact differ between community care and then someone who's received CSC, and what dollar impact does that translate to? So there's a lot of numbers going into this on the back end that actually add up into an aggregate number. So if you could just show the next page for one more example. So again, for example, how it looks for employment and housing, if you take the scenarios of someone receiving community care versus CSC versus the timely access, and how that changes the impact on unemployment rate, and then as a result, how much dollar impact that has for the system. And if I could just ask you to go 2 more slides forward, and then we'll, I think that should be the full set of material. So For example, California, as Kana had mentioned, used this methodology to they chose the endpoints of 10 to 90% of access, and that translates to around 2,000 to 19,000 individuals annually, and that generates around $850 million in annual system savings. Just a useful example of taking some of our similar methodology and applying it to a state-specific analysis. Great. I think that concludes the main presentation.
Great. Thank you so much. Just a wonderful presentation. And I just love the way you've broken down the model to really explain how comprehensive it is. And the more timely the access, the better. What a very knowledgeable, important concept with anything in terms of trying to get care there. We have a lot of questions in the chat box, a lot of curiosity. So I'm just going to go through those with you and start there. And Helen Bird from Nevada, although Helen needed to jump off, I think a lot of other people will have this similar question. Is there any research and or literature about establishing centers for excellence at universities to establish a foundation for scaling this model? Any ideas on that?
Oh, I see Deb Pinnell's entered the waiting room. Maybe Deb knows. But no, I don't. So I would say we did not necessarily, in our research, look at sort of the different training and upskilling models. So I think that's a great question. I would imagine that the way of expanding access and building the workforce is going to require things like COEs to help concentrate that knowledge and provide the technical assistance to do that. But that wasn't necessarily a focus of what we've done. But I would welcome others. I think this should be a discussion. So many of you have done this already and have seen what you have in your states or other states.
Great. Thank you, Kana. And we also have a question. What are creative financial strategies for sustainability, including any unique strategies for rural CSC programs?
One of the, and hi, Sherry, I think one of the, some of the models that we have seen, right, are, I don't know if it's necessarily financing sustainability, but obviously the use of tele and how can we use technology to expand access and have sort of a centers of excellence or a hub and spoke model for expanding access to CSC in general. Because of the difficulty of having that concentrated team-based staffing in lower density population hubs. The time and distance standards that certain states have implemented, right, that create opportunities for supplemental funding or other incentives for states that have lower density of sites. And then I think the other thing that's important is the states that are out there leading on trying to get commercial payers to require the coverage of the entire spectrum of services. Not sure that that's super helpful, but again, there are other states on who may have other important strategies that they've used. Would welcome folks to jump in.
Yeah. And if other states have ideas on that, please let us know in the chat box. Having the state examples is always really helpful. And Monica Luke asks, the costs are very high if CSC is delayed more than a year. It would almost appear that this data would suggest not providing CSC after 12 months. What about other outcome measures for getting into a program after 12 months, like returning to school/work, quality of life? Any clarification?
I think, Monica, that is a great point. As we sort of were saying earlier, this is mostly a financial or economic model, not necessarily a clinical piece of research. And 100%, we see that people who have access to CSE do have, whether it's early or delayed, do have better outcomes. But we're not necessarily, you don't see the dramatic drop in subsequent use of inpatient days or emergency department days. There are some reductions, but it is not as dramatic, and therefore you don't see as much savings. I don't think that's an argument not to do it. It is an argument to try to reach people earlier.
That makes
Again,
sense.
if you reach people with other chronic conditions who are at a severe, end stage renal disease, for example, I think, yes, it's very expensive to provide dialysis. It's very expensive to do kidney transplants. That doesn't mean we shouldn't do them. It's just it's much cheaper to prevent diabetes. As we all know, or it's much cheaper to maintain people on insulin and to reach them earlier so they don't reach that state of disease. But I will say, we looked at some analyses that some state kind of their CBO equivalents have done, and when they only looked at literature that didn't distinguish between early access and delayed access, they did end up saying, well, we don't see an economic case for doing CSC because it looks like it's more costly. And they also didn't look further out, right? So if you only look at doing CSC for 2 or 3 years, and some of the people you're reaching are not in that initial stage of onset, then you both don't get the benefit of reaching people early, right? You still have the high cost of delivering care to people who are caught later in their trajectory, and then you also don't see the longer term benefit. And so it's important that when folks are doing this economic analysis to costing out the value of expanding a program, that they're doing it in a way that makes sense for this particular clinical model and this particular disease set. And so again, I hope it's not taken that we're suggesting people should not get CSC after 2 years, because there are still important clinical gains and human gains. But just when folks are designing the programs, if they're trying to make the case to others, those are important considerations to take into consideration.
And kind of just to clarify something there, I would imagine if somebody didn't get CSC at all, and did a traditional inpatient care, for example, that would be astronomically, economically not helpful. But let me know if I'm off track there.
Well, I think to Monica's point, the way it's showing up on our model is that people who don't get engaged with CSC, we're not able to see some of that higher cost, right? Our model also did not take into consideration the cost of state hospitals. So we didn't. So this is only kind of inpatient, outpatient criminal justice housing. So because we don't have the cost of state hospitals integrated into this, and because some of those folks will also die earlier, so we did not take a years of life lived approach, or shorter life expectancy approach. That it does in some ways look like, oh, it's cheaper to not care for people than to care for people. But it's also because the people we care for, once they're engaged, we are going to actually care for them. We can document those costs. The people we didn't care for, they're not necessarily visible to the system, and some of the costs are not captured. Doesn't mean that it's better or more effective or actually less costly, but that we couldn't necessarily capture them all. And to your point, Megan, it is quite devastating to family and others.
Okay, great. Another question came in. No, we do have a new administration. And does this change the strategy for next steps? Like, how can states use this paper to promote the need for maintaining of the CSC model, even if there are budget cuts?
I think that's a great case. I mean, I think of course, we were using this. There is a literature on first episode psychosis and the cost of care and the relative cost benefit. So again, we did not build on that. There are papers by, the On Track folks, by Bob Rosenheck and others that you could draw from. I think this, but still, this model could be used. I think because it lays it out fairly in a straightforward way, right? Like, you're not just handing someone a journal article, but you can kind of show the charts and show, like, here's the folks that we are keeping out of hospital, here's the folks that we're keeping out of CJ, and how that translates into real world costs. So absolutely, I think that makes the case for why these programs are important to preserve as they are, as well as, to grow over time.
All right. And getting back to some of the financial strategies there, Kyle Barrett says, similar to the previous question about financial strategies, have you come across any reports or information regarding the experience of states or health systems that have attempted to leverage new CMS billing codes for CSC to support implementation and scaling of CSC?
Kevin, that's you.
Well, because those codes are also so recently live, it's a bit, to incorporate reporting on them into the paper was a bit more challenging, but that is something we're exploring. We're fans of data, obviously, and have access to some CMS research data sets, such as the TMSIS data set, for those who are familiar with large claims data, and are studying that right now to see where those codes have had greater adoption, and then what some of the utilization patterns are with them, and potentially, because the codes became recent and because there's always a lag, but we probably will have to wait to really see the downstream results. But hopefully, once you see those changes in utilization, you can also see a shift in the way the downstream care is utilized for the same individuals. So we're really excited about those codes because it actually gives a much more clean way of tracking the impact of this program through administrative data sets. But it's just given the sort of timeliness of it, we will have to wait a little bit longer to actually see it come through. But I love the question, Kyle. We're excited about that also.
Mm-hmm. Yeah, thank you. And this is again in the context of where states are today. Is there the potential to apply your model, or even parts of your model, to quantify savings at a state level to use specifically for state level advocacy? And that's asked also by Kyle Barrett.
Yeah, so yes, this is the short answer, Kyle. We were hoping that that would be a way to use this, and we have been working on generating versions of some of those key charts that you just saw at the national level, versions at the state level. Every state is different, of course, and it's we've done our best to make these assumptions sort of nationally relevant, but we've built the tools to recreate it at a state level. So if you or if anyone would be interested, we'd be happy to share that, so that you can have the same type of conversation at a national level, but at a state level.
Yeah. And I should qualify. So we did this in collaboration with NASHPD, National Council of NAMI, and MHSOAC. So the report itself is available on NAMI's website. And we're at the McKinsey Health Institute. So the products that we help create need to be made available to the public at no cost. So we're happy to share the as Kevin said, the model and some of the assumptions that were put into it so that states could do this on their own.
Great, great. And Louise Johnson asks, is this model similar to SAMHSA's Healthy Transitions Initiative across the states, especially the use of drop-in centers that are staffed by peers?
I'm not sure if the question is coordinated specialty care. I mean, healthy transitions, and for, it's been some time since I was at SAMHSA, but, my understanding is for our transition age young people, and it is the same population group, and hopefully in healthy transitions you can identify kids that are at ultra high risk or experiencing a early psychosis. But coordinated specialty care is a very distinct set of services that are offered in coordination for people within that onset of a psychotic episode. So slightly different research base, but the intention is, I think, things like healthy transitions are very important, because if we're going to catch folks sort of in the year of incidence, or when they're first experiencing these problems, it's very helpful if we're already engaged with them, that we can see any changes in behavior or thought very early, and then connect them with the CSC program rapidly.
Great. Thank you, Kana, for that clarification. That's really helpful. And Megan Sage asks and notes that Oregon has a Center for Excellence for our CSC programs through the OHSU PSU School of Public Health. Megan is happy to talk with anyone who is interested on how they provide technical assistance and training for their programs in Oregon, as well as several national programs. And so Megan's email is in the chat box there, and I'm seeing lots of hearts and interest on that. And so with that, are there other states that you're aware of their approach on how they have been able to expand the CSC model?
Sorry, I didn't know if you're asking Megan or if you're
Yeah, I am. Yeah. I'm just wondering, sorry. I'm wondering, are there other state examples that you're aware of how they actually approached expanding CSC?
I think there are a number of states that have identified COEs. I think there's also the EpiNet, which is supporting the backbone of these programs around the country. There's been considerable technical assistance, and states trying to do this. I know there's also been some innovative partnerships with payers who have either contracted some parts of CSC or wholly. But we're probably not necessarily seeing the level of scale or statewide-ness, other than some of the, I would say, probably smaller states that have been really successful at that.
Anything else you'd like folks to know? Any closing? We don't want to have to close, but any kind of concept you really want people to take away today?
First of all, appreciation for the incredible partnership with NASMHPD. Megan, you, Jessica, Brian have always been and continue to be fantastic partners. The main takeaway is appreciation for the leadership from all the states in advancing these programs today. We have seen growth in the programs. We are seeing growth in access. But what I hope people take away is the strong encouragement, right, to continue to make the business case to, at baseline, protect your programs, preserve them. They are life enhancing. They are vital to our community and to the folks that we serve. and also to look toward private sector partners and the advocacy that needs to be done, because so many of the young people that experience their first episode of psychosis are under the age of 26. They're still on their parents' commercial insurance, and commercial insurance isn't necessarily covering, paying attention to covering this population as they should, and they are getting subsidized by your programs and by the block grant. And I think we're hoping that this is a tool that can be used to make the case that this is an essential benefit. This is part of parity. This is something that should be covered by every plan as they would cover any other evidence-based intervention for a serious health condition.
Absolutely. Kana, as a follow-up to that, is there anything states could do to make the case you just said, that private insurers need to do this? Is there a role?
Certainly, I would encourage people to look at the California strategy that they did. They identified what proportion of this population is already on Medicaid or has is dually eligible, how many of these people have commercial insurance, and what proportion of that needs, where you need to see some step up on that side. And then also, Kevin is very generous with his time. So I'm sure he'd be happy. He'd love to have a chat with anyone in terms of looking at the data a little bit more carefully for their state.
Wonderful. And if people wanted to contact you for follow-up, what is the best way to do that if they have questions?
You beat me to it. Yeah, you can reach either of us by email, of course, at our McKinsey email addresses, just as I'll put Kana's in. She put mine, so I'll put her email in the chat, and either of us would be happy to talk more about it.
Are you
Kana,
on mute, Kana?
you're on mute, I think.
Jessica Pollard, who wasn't able to join us today, but is on the NASHPD team, is an amazing font of information, is a vital advisor to us in this process. So I think Jessica doesn't have access necessarily to all the data that we have, but has just tremendous information and expertise.
Wonderful. Thanks for underscoring that. Jessica's fantastic. Let's see. And also, Megan Sage says, I would also encourage everyone to center the lived experience perspectives of the young people and family members that have participated in CSC to help advocate for funding and expansion and to compensate them for their time and expertise. Nice. Yes. And
just
then
to underscore that, we did do a very thorough effort to try to engage young people. We did talk to some young people and family members, and did compensate them for their time for the creation of this report. So thank you for that.
Excellent. And getting back to the private insurance piece, Monica Luke says, not paying for CSC is a parity violation per parity experts, Henry Harbin, David Lloyd, and Tim Clement. So, and I know others have worked on that as well. So just want to thank you so very much for being on. This is so timely and can really be part of state strategies right now and a positive move forward. So thank you very, very much. And we look forward to our continued partnership with you. Thank you, Kana. Thank you, Kevin. Great. Thanks. And now we're going to move to a brief policy update with Aaron Walker. Go ahead, Aaron. Thank you.
Thanks, Megan. Good day, everyone. Just have a few resources I wanted to just share real briefly. If we go to the next slide, please. First up, from the Center of Excellence for Tobacco-Free Recovery, they have a couple of upcoming webinars. Just want to make sure that you knew about. On February 27th at 1 p.m. Eastern, there's the Emerging Evidence to Inform Tobacco Use Treatment for Adults Who Dually Use Cigarettes and E-Cigarettes. Again, this is 1 p.m. Eastern on February 27th, and you'll see a link here to be able to register. And then upcoming on March 20th at 2 p.m. Eastern is the Power of Incentives Contingency Management Approach to Address Tobacco Use for Individuals with Mental Health and Substance Use Challenges. And you'll also see a link here to be able to register for that as well. Next slide, please. And then we have 3 resources from the Center of Excellence for Protected Health Information. This first one is the Notice to Accompany Disclosures of Information. This is where organizations that provide substance use treatment services may need to share information with other organizations and professionals for care coordination or other purposes. So this resource reviews important information that program administrators and providers should know when they share patient information protected by 42 CFR Part 2, and you'll see a link here to view the resource. Next slide, please. Also, there's a state agency leaders resource number 6, sample provisions for an integrated QSOA BAA to disclose PHI with contractors. So this is looking at during the course of providing substance use treatment, you may need to share protected health information with an outside entity that, such as a contractor for services like accounting or data processing. And this provides sample provisions for integrated agreements with outside entities related to sharing PHI for use by Part 2 programs that are also HIPAA covered entities. And again, another link here to access the resource. And next slide, please. And last but not least, there's this implementation fact sheet. And this is intended to assist Part 2 programs in complying with the requirements of the final rule by describing in detail 3 key steps that programs can take to support implementation. So you'll see, again, a link here to access that resource as well. And I will pass it back over to Megan. Thank you very much.